Um, Welcome to our last class. I say that with some real nostalgia, which we'll revisit in a little less than an hour. So we have today, as you know, a long-awaited speaker who I'll introduce you to in a moment, and who I will let introduce herself and her work, because that's what you're going to get to hear about. But I just want to give you a little preamble. So um, this is, like I said, our last class. We'll be sending you information about the final exam and completion dates for activities after this class. We'll review that briefly at the end. We are standing by to be helpful, and we'll talk about that at the end as well with your completing those tasks. Um, Today, what we're going to be concentrating on as a really nice curtain call for our course together is a deeper dive into community and the importance of understanding and knowing how to effectively work with communities as a leader in public health. And my first exposure to this in a deep and meaningful way was when I was doing my 3-year long postdoctoral fellowship at Stanford under the supervision primarily of Marilyn Winkleby. There were a lot of people who could have potentially been mentors, but Marilyn was the clear go-to choice for multiple reasons. One was her set of skills as an extraordinary epidemiologist. The other was her dedication as a mentor and nurturer. And the third was her sense of mission, which, like many of the people who've spoken to you in this series, was deep and motivating. And that to me is one of the most important things that I hope you'll take away from this class as well. In terms of the communications things we've talked about, is how can you effectively motivate your constituents. And Marilyn's going to be showing you about that, both writ small and writ large, based on the extraordinary community intervention that she co-led with our colleagues at Stanford. So, Dr. Winkleby, would you like to go ahead and dive in from there?
Sure. So thanks for having me, everyone. And I'm going to tell you about the Five City Project, or the Stanford Heart Disease Prevention Program that took place in 1980 at the height of the CVD epidemic in the United States. And it's when I had just finished my PhD at Berkeley, which is a public institution, and I had come to Stanford, which is a small elite private institution. And I am the first epidemiologist on this 10-year study that's been run by MDs and communication professors. And so I inherit the last surveys and the last part of the intervention, as well as 10 years of cleaning data that had really never been looked at. And then I'm in charge of overseeing all the publications that come from this. So you're welcome to ask questions during this. And I'm going to now see if I'm smart enough to share the screen. So let's see.
So again, that green button, there you go. Perfect. Yeah.
No, it's not perfect because I can't see it yet. Okay, now I'm going to go down. There. Can everyone see this well?
Sure can. Thank you.
Okay, so I want to tell you just a little bit about the historical approaches to addressing CVD. So it's 1959, 1960. This is the first major response that NIH launches to the CVD epidemic by health professionals. And I'm going to come back to this because I'm going to tell you a story about President Dwight Eisenhower. So in the 1960s, our way to intervening on CVD and, quote, curbing it was we focused on high-risk individuals. So that's a medical model, right? And we thought, if we just get to the high-risk individuals and tell them to lower their blood pressure, to exercise, to eat better, that's going to be good. So I have to ask you, someone, did that help the high-risk individuals? You have to unmute to tell me. Was that effective?
This is not a trick question.
No, it was not effective.
Okay, and why wasn't it effective? It was effective for the person sitting there with hypertension talking to the doc, right? That was effective because they put them on antihypertensive medications, but it's not effective because what's happening to the incidence and the prevalence. So the cases keep coming in, right? They keep streaming in. So you can take one little high-risk person out, but a population approach, you're trying to shift the distribution of the disease. So in the 1970s then, NIH and the medical doctors in the United States and researchers decided, well, we'll take moderate risk people too, along with the high risk people. And we won't take a person that just has one risk factor. We're going to take people that have multiple risk factors. So there were a number of trials on that. And that worked a little better, but it still didn't get around this problem of trying to shift the distribution in the community to lower the risk of everyone in the community. And in the mid 70s to 80s, then was this big funding effort by NIH for funding 3 interventions to target all individuals at the community level. And that's the public health model. And that's what I'm going to tell you about. But I want to go back and tell you about Eisenhower, because Eisenhower, this is the post-World War II general. He's coming home. He's just incredibly popular, right? He's president from 53 to 63. So this is the height of the epidemic. And does he smoke? You just have to remember, we're sending cigarettes overseas in World War II to everybody. So everybody's smoking. He's not just a smoker. He is smoking 4 packs of cigarettes a day. So he has an approval rate of almost 80%, which is just unheard of now in the United States. And he's a big golfer. He's out on the golf course when he's 64 years old and he feels like he has a little indigestion. And 24 hours later, he's in the Army hospital and he's had an acute MI. And the Dow Jones Stock Exchange lost $14 billion in that day. So he's hospitalized for 6 weeks. He runs for re-election then. He continues smoking. And at that point, nobody that had, if you remember, FDR is in a wheelchair, but he hardly shows anybody who's in a wheelchair. So no one who's a major figure talks about heart disease or cancer. And Paul Dudley White comes and he's Eisenhower's personal physician. And he's from Harvard and he's the guy that founded preventive cardiology. And he says, Ike, that's what they called him. You really need to publicly proclaim and inform the public about all aspects of myocardial infarction and about your health. And he does that. And Paul Dudley White is this big guy who rides his bicycle and he's concerned about cholesterol and weight control. And he even starts talking about stress. And so along with this is the first awareness of not only the population about the risk factors for CVD, but the health professionals about CVD, because that's not even widely known, because a lot of the docs in the United States at that time, they're private doctors. So this is the setting of then the 5-City Project. And I want to say just a brief thing about the importance of chronic disease risk factors. I'm not sure, have you read any of these JAMA articles that show you that the majority of all deaths are linked to CVD risk factors, right? So 73% are due to tobacco, poor diet, and physical inactivity. Oops. And so you can just see here's tobacco, 39%, 34% for poor diet, inactivity. Here you have Yeah, those are the three. And so that's 73%. So we know what is causing deaths in the United States and what needs to be addressed. So NIH comes out and they put out RFPs for these 3 comprehensive community level CVD prevention trials. NHLBI funds them, heart, blood, and lung. And it's this huge paradigm shift to say, we're not going to just fund the doctors to sit down with those who are at high risk. And so the first was what we were over, which is the Stanford Heart Disease Prevention Program. It's also called the 5 City Project, which I'll go into the design. And then Minnesota was funded. It had 3 treatment and 3 control cities. Stanford had 2 treatment and 3 control cities, and then a surveillance city. And then Pawtucket, Rhode Island was the last one, and it had 1 treatment and 1 control city. And they were independent. And so the communication that's used, the kinds of interventions, the kinds of volunteer and activism during this, it's specific to each of these trials, although they're all charged with changing CVD at the community level. So here's the rationale, right, for your population versus your high risk approach. So right down here, here's your distribution of cases according to the risk factor level, bottom of the x-axis, right? And here, 5% of your, this is the distribution of diseases, of the cases, CVD. Here's 5% are low risk, right? They're out here at the tail of the distribution. 25% are over here at the high risk level. So the high risk approach is to treat these, identify and treat these guys and women, right? But a population approach is going to say, right here, we're going to shift the whole distribution of cases from here to here. And by doing that, the whole community is ensconced in a healthier lifestyle, and it shifts the risk factors to the left. And we know now that that's the approach that is by far the most effective. And it's also the approach that demands a whole lot of partnerships and communications and genuine trust with communities. So here are the 3 trials, and I'm sure that you've heard about community engagement a lot in this class, but just this is NIH coming out in 2008 saying that community engagements is the process of inclusive participation, right? That supports mutual respect of values, strategies, and actions for authentic partnerships. People affiliated with or self-identified with some kind of geographic proximity. Might be a city, it might be a town, it might be a group of Stanford employees, something that makes a common interest, similar situations that addresses the well-being of the community in which those people live. And what you're talking about when you talk about authentic partnerships, it's really different than a lot of research that's going on at the time where an RFP gets issued, you go to a community, you say, we'd like to partner with you, we'd like a letter of support, and you go in and you survey the population and you intervene and they never hear from you again. So authentic partnerships take a long time to build the trust, right? And they involve partnerships at every part of the design, implementation, and the dissemination of your findings. The educational goals for all 3 studies is to achieve a detectable net decrease. So it's not just a decrease. So a net decrease is what? So you have treatment and control cities in all of these. And what am I looking for? I'm looking for a difference between what? Am I just looking for a decrease in heart disease in my treatment cities and control cities?
Again, promise it's not a trick question.
I'm not going to give you any trick questions. I know you guys know this.
Yes. Yeah. Exactly. Are you seeing Callie's note there? Dr. Phillips's note, Marilyn.
No, I am not. But if somebody can, if you can just unmute and speak.
Yes. Hello, Dr. Winkleby.
Hi.
Yeah, I was saying that you want a difference between the control and treatment with a p-value significance.
Yeah. So you're not just interested in everybody getting better. You're interested in that your treatment gets better than your control, and that it's a net difference. And like you say, there's a p-value or some statistically significant effect of that, right? And then another educational goal then is you want to leave a functioning community health education program. So you don't want to just be in there for 5 years or 10 years and then leave and forget about it. And during all of this, you're developing a set of tested materials for both mass mediated, because it's community level, as well as interpersonal health education. We're going to show a lot of that. So our focus then in these trials is on both the prevention and the treatment of these modifiable CVD risk factors. And the nice thing about CVD risk factors is that once you know them, you can modify them, right? And so you can modify, or you can continue to reinforce good behaviors for all of these: cigarette smoking, physical inactivity, high dietary fat, overweight, obesity, high blood pressure. Same as it is now. Stanford Heart Disease Prevention Program. So what did we do? So here are the key investigators. And these are the main people that you'll see on the 150 or how many articles that we wrote. Lots of things that we wrote. And Jack Farquhar, here I am with Jack at the bottom here. He also began our center. He's a cardiologist. At the time, for a physician to begin talking about, so he's a lab guy. He's a cardiologist, he's a clinician, and he's a lab guy. He's pretty famous in lipids already. And he comes out, and this is North Karelia and Stanford. They start talking about, wow, maybe we should be talking about being in the community, which is really radical at the time. Okay, our design. So we picked 5 cities: Salinas, Monterey, Modesto, San Luis Obispo, and Santa Maria. We have 2 intervention cities and 3 comparison cities. So one is just a surveillance of mortality follow-up. So that's why it's called the 5-city. And there's a 6-year multi-factor intervention on all of these CVD risk factors. And along the way, to evaluate it, they do something that's really clever and useful. They do 2 kinds of designs. They do the cross-sectional surveys and they do cohort surveys. And we're going to talk about the advantages and the disadvantages of both. And then the advantages of having both of them, because you can see if your results are then consistent. And those are conducted every 2 years between 79 and 90. So here we are. Here's Stanford up here. Here's San Francisco. Here's the Golden Gate Bridge. Here's the Bay. Here is San Francisco. Here's San Jose. Here's Stanford University. And here are the 2 treatment cities. So Salinas and Monterey, they share a media, which you want, right? And they're far away from these other cities, so you don't have contamination of your media. And here's Modesto. It's in the Central Valley of California. Here's San Luis Obispo, and Santa Maria then is the surveillance city. I'm going to tell you about these cities. Okay, so here's the intervention cities, and it has a very receptive county health department because we work a lot with them. Here's the comparison cities. So Modesto, so you don't live in California, but these are, so they're matching. So they're looking all over Northern California. And what are they trying to do in finding these 4 cities that are intervention and, well, 5 cities really, comparison cities in the mortality. So you don't want something that's huge and something that's really small. What are the things that you would have to look for in selecting your cities? If I'm giving you millions of dollars today to say, hey, come back to me in 2 weeks and give me 5 cities that we're going to intervene on at the community level, what might I want to hear? Do I care about the size of the cities and whether they're a comparable size? Yes. So you've got to get comparably sized cities. I don't want something that's as large as Los Angeles that has 10 million people. I have to have a small city that I can actually be intervening, having partnerships with the schools, with the health department, with the government officials. So I want something that's not tiny, but I want something that's fairly representative of cities in California and the United States, even though we're a huge country. And I want them about the same size. So they did really well on picking Modesto, because Modesto is the same size and it's about demographically not too dissimilar. It's semi-rural. It has a sizable Latino population like Salinas and Monterey. And then they make this really curious choice of another control city that's not supposed to change much, right? You don't want your control city changing a lot more than your treatment cities. So San Luis Obispo is a college town. And what's a college town always going to do? A college town is going to be aware of things ahead of everybody else, right? They're going to be much more likely to change on their own. And we'll see the ramifications of picking that. So right at the design stage of a community intervention, if you pick the wrong kind of case or control city, it's going to basically help or hinder or ruin your results. Here's the intervention. So it goes on from 80 to 86. It's this risk reduction program, and it combines all sorts of things. So you cannot live in these two treatment towns, Monterey and Salinas, without knowing about this intervention over 6 years. Your cities are just blasted with these. So we have all sorts of print. We have booklets, we have kits, we have newspaper, newsletters. We have a lot of direct education that's in schools, classes, churches, lectures. There's all sorts of stuff on the small shared radio stations and TV. And there are contests. And then there are environmental changes, which are going into restaurants or grocery stores. And the restaurants, you would be asking for meals to be modified to be healthier. And grocery stores, at the time, everybody's drinking whole fat milk, which is at eye level, and you're trying to get the non-fat milk and the lower fat milk moved down and switched. So you can see that at eye level. So that's more likely for people to pick it. Okay, here's some of the things that were done. So here are the mailed kits, and these are large kits. They're developed by this large communication team in our prevention center, and they're overseen by Nathan Maccabee, who is the head of communications at Stanford. And you open this kit and it's got these about 10 glossy pages that tells you, number one, how you get started thinking about walking, how you keep moving. And there are 4 steps to this. And these are so state of the art. They're not only used for the 6 years of the intervention, but after the intervention, there's a global distribution of these where there are hundreds of thousands of these kits that are distributed. And there's, let's see, a smoking kit and there's a nutrition kit as well. So these are mailed. They're mailed to every address in these 2 treatment cities. Here's a healthy recipe book. It's mailed too. And at the time, there's not a lot known about healthy recipes for cooking. So how do you broil instead of fry your meat, for instance? How do you pick the size of meat compared to vegetables on your plate? And it's telling you how you can really cook very good meals that are either with or without meat and lower in fat that are very tasty. And these are tried in home economic kitchens, and then it's distributed. Here's how to quit. So we had a cool turkey quitting guide. It gets sent to everybody. And then if you go to the grocery store, and as well as mailing, These are things that are put in the bottom of grocery bags. And so every time you come home from the grocery store, there is one of these things. And so it might be on cooking methods, or it might be on cardiovascular risk factors. And people then go and they're very colorful. The color coding stays across everything. It's been heavily evaluated, informative evaluation to see what kind of font people like, to see what colors people like, what kinds of receptiveness people would have if they are in their grocery bags, if they'll even read them. And then at the time, there is beginning to be a stable Latino workforce in especially Monterey and Salinas, and you don't see anything. I mean, everything's translated now, right, into many languages. You don't see anything in Spanish. Any health education materials show a white doctor in a white coat with a stethoscope around their neck, and it's in English only. So this is one of the first educational campaigns in the United States that starts translating things into Spanish. And then going specifically to the Spanish areas where the Mexicans are living in Salinas and Monterey. And then here's Jack Farquhar, the founder of our center and the PI of the grant. And he comes out and he's got a weekly column in the main local newspaper that's not only in English, but in Spanish. Here are interventions at the school. There's not nearly as much of this as that you would think. If you're designing an intervention today, probably your main kinds of things would be these more environmental changes, because the others are pretty much an individual change, hoping that if you just get the information to the person, they will maintain their good, healthy lifestyles, or they'll change to the better. At the time, here you can see, here's a school, and here's a young man standing by Pepsi-Cola. So Pepsi-Cola is actually funding the schools to put vending machines in the schools to sell Coke and to sell Pepsi to the students. And so we worked with the schools to get the vending machines not to sell any soft drinks. Here are contests and walking clubs. So I have to ask you, so here's this quit smoking contest. This is citywide, and you can win a trip for two to Hawaii, and it's been donated by a travel company. And there are rules for entry, but it's trying to get people to stop smoking. How are contests viewed? Are they a popular way to get people to engage in a community action? What do people think? Do Americans love contests?
People in general love contests. The competitiveness, it's exciting, it's like team football or something.
Exactly. People loved the contest. In fact, it was so inexpensive to do it because you could get things donated, right? And there would be walking contests and running contests, and there'd be a lot of news coverage about it. And people really, really came out for the contest. And you're right. It's probably worldwide that people like contests, right? Now here's the labeling. So here's Sizzler, which is a big fast food kind of appealing to middle income people, and it's got steak and seafood. And so here you see this little red heart. So these little red hearts, they're also a magnet, and these magnets were sent to every household. And it's impossible not to go into a home, or to go into a home in Salinas or Monterey and not to see these little red magnets on the refrigerator. So this is carried over to labeling in the restaurants. And here we've worked with Sizzler. And so here you see that they're now offering a grilled salmon fillet, and they're offering a grilled swordfish and a grilled red snapper. So before, Sizzler is just known for frying everything. They're still known for frying a lot of things. And it's got the cost, and it's got your little heart, So you know, as you go into these different restaurants, what is heart healthy. And then here are billboards. So there are billboards as you're driving, give your heart a lift. And the thing that they are doing that innovative again is there it is in Spanish. And for the Latino population to see something like this, not only print material in their grocery bags, a weekly column by Jack Farquhar, by the doctor, but a billboard in their community where everybody can see it. And this is over all of the grape vineyards and the lettuce fields. Salinas is called the lettuce bowl of America, the salad bowl of America. So this again is very innovative, and it gets the cooperation and the attention of the Latino population. Okay, so how do you start evaluating an intervention like this? There are all of these levels of evaluation, and you're again engaging your community, you're talking to them, and you're saying, hey, how can we make this intervention before you're designing it to really appeal to people so they will be aware of it, there will be an intake, and hopefully that they'll change their risk factors to have healthier lifestyles. So the formative evaluation was extensive because that's that whole group in our prevention center. And it's taking place before or during the implementation. So it's taking place before, but then all through this 6 years, they're continuing to go to the community and ask them how they can improve the media and to implement this in a better way. And then there are the risk factor surveys. I'm going to explain them. We have biochemical and physiologic measures. Then we have clinics all over these 4 communities because we're doing the same in the control communities for evaluation, for risk factor evaluation, except we're doing no intervention, right? So we have nurses in our communities in where they're doing the surveys and they're drawing the blood and doing exercise. But then the nurses are also going to the hospitals and they're asking all of our survey participants all of the places that they have gotten their medical care in 6 years. And we get approval by the hospitals, which you would never get now, for their nurses to go in and sit and abstract the medical records and go through the hundreds and hundreds of paper, because it's before the electronic medical records, right? To abstract about the cardiovascular risk factors. Are they smoking? What are their lipid levels? And then you're doing a mortality, a death certificate search, which is statewide and nationwide, and you just get approval from the state for that. So that's a pretty easy one. But this is the one that's really, the surveys and the hospital records are the labor intensive. The evaluation goes on from 79 to 90. So we randomly don't select people, we randomly select households. And we want anybody ages 12 to 74 in that household to participate in our survey. And those surveys then are a random survey of the community that will hopefully tell us about net changes between your treatment and your control cities. So we have the cross-sectional and the cohort surveys, and they're each about 1,800 to 2,500 participants. Overall response rate, because you're asking people to come into a clinic, you're not just saying, hey, can I phone you or can I come to your door? You're asking them to bring anybody between 12 and 74 in their homes to a clinic in their city. Oops. For a pretty thorough assessment of their risk factors. So we do 5 independent cross-sectional surveys, these one-time cross-sectional looks. And then from the first cross-sectional survey, which is the baseline survey, that forms our cohort. And those people, those 2,500 people, are asked to come back 5 times every other year. And then we have morbidity and mortality that we've talked about from the medical records and the death certificates. So here's the evaluation. So here we have from 1980 until 86, that's our 6 years of an intervention. And then we have some maintenance that goes on until the surveys are still going on until 88. Here are the cross-sectional surveys. So I'm just taking a random sample of the 4 communities, one point in time, right, at this time. Then I'm drawing another random sample here, drawing another random sample here, another random, and another random. So the likelihood that anybody is duplicated in these is really low because these towns have many more people than 2,500. They're about 50,000 at the time. Okay, and then here's our cohort. So you take the first cross-sectional survey, those 2,500 people, and that's your first baseline cohort survey. And then those people are asked to come back. Very same people are asked to come back here, 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 and a final one to evaluate maintenance. And then at the same time of the intervention and all the surveys, you're doing your morbidity and mortality surveillance. So I'm not sure, Erica, how much have you gone over kind of survey research and cross-sectional and cohort designs? Have you?
No, this is really, WHO wanted us to focus on the skills of leadership per se in this, so
Okay.
not at all.
Okay, so so a cross-sectional sample, this is data, one sample at one point in time, right? So the advantages, there's some nice advantages. It gives you an accurate picture of the entire community. It's a random sample, and it's not affected by dropouts because you go and you get them and you want them in and you're not following them over time. The disadvantage is that you're not following the same women and men and children that are exposed the whole 6 years. And so if people are moving in and out of the community, you're not getting the people with the highest possible exposure to your intervention where you hope to see the most change. So you have in migration and out migration, but you have in migration of those not exposed. So if you look at this survey, you might have new people that have just entered the community there, but your intervention, they have missed all 5 years of the intervention up to that point, right? But you have a real-time look at your community by doing that cross-sectional survey. Now, in contrast, your cohort survey, same sample over extended time, right? So the baseline controls for the level of risk, and you've got a stable population group over time. And then you can start really looking at the change process. The disadvantage, though, is these guys, you might have out migration, right? So by the time you get to the 4th cohort survey, these people, they may have moved away, right? And so you're getting people, but you're getting fewer people. And you're getting people, you may be losing some of the people who are the most exposed to your intervention. And besides that, you might have selective dropout, and it's not selective dropout of those who are in your sample, it's selective dropout of who's willing to come back in repeated times and who might be a little wary of coming back in. You kind of understand according to the surveys when they're asking about exercise and diet and smoking, it's not hard to kind of figure out what we're up to, right? Even though we aren't telling them all of the hypotheses. So if I'm a heavy smoker, by the time you ask me to come in the 3rd or 4th or 5th time, I might think, I don't really know if I want to go there anymore. And I know that they are going to do a thiocyanate so you can tell if I'm being truthful about my smoking status. And then the other thing is you have a testing effect. So you have asked me the same thing in all of the surveys and modified a few things each survey, but basically 80 to 90% of the surveys that are asked, the questions are repeated measures. And so somebody may be less likely to answer in an accurate manner over time. So you've got a lot of nice advantages, especially this analysis of change process, but you've got these disadvantages. But you've got cross-sectional too. So you've got both going on and you can look at the results of both. Okay, So here we've got our community clinics, and we're going to collect all of this from our surveys. And so you go in and we're going to get all sorts of demographics. We're going to get, you know, your gender, your birth date. We're going to get your ethnicity, where you went to school, your highest years of education. We're going to ask you all about your health attitudes and knowledge concerning cardiovascular disease. And then we're going to ask you about your risk factors for CVD. Self-report the medical history, because we need that to go to the hospitals to verify what you tell us. And then we're going to ask you about how you communicate and where your patterns about talking about cardiovascular disease and health, and the people that are most influential in telling you about it. In the clinic also, besides sitting down and getting these surveys, because this is really before laptops, we're going to get your total cholesterol. It's a non-fasting blood sample that we have to get, your HDL and your LDL. And a big incentive of people coming in and participating is at the time, people don't get their HDL and LDL. It's just being talked about. So at the end of every survey, we're sending people their risk factors, and we're sending it to their physicians too. And then we're getting the expired air carbon monoxide and thiocyanate to confirm smoking status. And I have to tell you, hardly anybody lied about smoking status. And here in the clinics, then we're also doing BMI, height and weight. We're doing blood pressure. We're doing a manual reading with a sphygmomanometer. And then we have this new machine, which is this big box that you put your arm in, and it's one of the first automated blood pressure findings. And the findings come out in a little circular disc that is going to be a story a little later in this talk. We're getting your pulse rate, and then we're getting a low-level exercise test, which is on a bicycle. Morbidity and mortality, to evaluate that, we're going and getting your outpatient health conditions at a clinic visit, right? They're reporting that. So they're in the clinics and we're just saying, you know, do you have hypertension? Are you smoking? So we're not going to outpatient health clinics. We're getting that self-reported. Then they're signing the release for their inpatient medical records when they've been hospitalized overnight for at least one night or more. Nurses go to the hospitals, abstract the records. We do all sorts of quality control on their abstracting. They re-abstract 5% of the records to verify accuracy. And then we're searching death certificates annually. Here are the results. So we're really hoping. So NIH has put in so much money for this, and they're hoping that Minnesota, Pawtucket, Rhode Island, and Stanford Heart Disease Prevention Program are going to change the thinking about how we address cardiovascular disease for the next generation of interventions in the community. Here's our education exposure. So it's on average, an adult will get 26 cumulative hours of education from us. And they're going to, some of it's targeted. So you have to think about what's in the grocery bags, what is in a class that you might take, what is at a church, what is in the newspaper, what's in the local TV and radio stations. Some is specific just to blood pressure. Some specific to smoking, quitting smoking, some to exercise, but by far and large, most of it's general, multifactorial. So if you hear about one risk factor, you're hearing about all of them. And then a lot is on nutrition and weight. So we're really hoping that maybe they're going to change their BMI, right?
Just wanted to interrupt, Marilyn. You wanted me to let you know when you have 10 minutes. So
Okay,
you do.
thanks.
Yeah.
Okay, here's by channel. So we have 34% is on local television and radio. We have a bit from direct education. Here's a whole, so the most is by your print, right? And there are just numerous ways we're getting the print to them. Then followed by TV and radio, followed by the print, newspaper, and newsletters, and then a bit of direct education. So here's the main risk factors. This is net reductions. What's favoring the 2 treatment cities compared to the 2 control cities? So there's favorable secular declines in all cities. So everybody gets better. So you go, wow, this is great. You know, everybody's getting better. The total mortality risk score, which is based on Framingham, is 15% lower. Coronary heart disease is 16% lower, right? Smoking, it changes in the cohort, but not cross-sectional. Blood pressure, all of these have a 2 to 3 to 4% difference in net reduction. And the cross-sectional surveys have a similar pattern of change except smoking. So this is 5 cities, so you can say, this is pretty darn good because they're very different kinds of survey and we have similar net results. So here it is. You're going to get these slides, I assume. So knowledge, so here's the cohort sample, here's the cross-sectional independent sample. Everybody, this is the 2 treatment cities, and these are the control cities. So they're increasing their knowledge about CVD. And then the big changes here are among smokers. The smokers are really decreasing a lot more in the cohort, right? And you can see that all of the changes are really doing better in the treatment, except these little guys over here, BMI especially, that's not showing anything. In fact, it's showing then the independent surveys that the controls are doing better. So what does that give us? So that gives us significant findings in 5 city, and Pawtucket and Minnesota at the same time are showing no significant findings. However, here is just a quick study about quality control and communication. So it's not only communication with your team to build a team, it's not only communication in the community, it's communication with your researchers. So I'm here and I start analyzing these 10 years of data, and I find that the nurses at one of the clinics in our control city in Modesto in Central Valley, all of the readings end in as 80% of the readings end in a 0. So it's 140, 150, 90, when you would expect them to equally be represented in 2, 4, 6, 8, 142, 144, etc. So she has gotten digit bias. She's got the sphygmomanometer. She's letting the mercury drop too fast and she's just rounding them off, and they're always ending in 0. And so you cannot trust the blood pressure findings. And so you have to basically throw out the blood pressure findings of one entire control town for 6 years. My first meeting, after being hired, going to Jack Farquhar and the PIs and co-PIs, was going and telling them that they couldn't release their first JAMA paper of main results because the blood pressure findings were biased. And so we have these little discs, right? And I said, well, where's the reading of the disc? Well, we haven't read them. They're in shoe boxes. So there are something like 10,000 of these little discs, and you can learn to read them. But the only person that knew how to read them was a person in Louisiana that was doing a heart disease study. But when I called, he had recently been killed by a truck. So I finally found somebody that knew how to read these, could train me, and I hired 10 Stanford students over Christmas break, and they coded about 10,000 of these discs. Now, the ironic thing is that the findings for blood pressure then were even more significant. And this is what really drove the main findings of 5 city. Okay, so this is just a little background about how it takes about a minute to code each of these discs, at 3 months to complete it. And here is a memo to me from our research aides that we had 26,000 discs to code. And here is our communication is going on daily in our research group. Okay, so what happened in Minnesota and Pawtucket? Neither of these show significant results. So I'm asked to do a pooled analysis to pool all the cities from treatment and control cities on the 12 cities in Pawtucket, Minnesota, and Stanford, because you can estimate the intervention with greater sample size and statistical power. And what I find, just like in the smaller studies, the net intervention is mostly in the expected favorable direction. However, when you pool them, because you've got Pawtucket in Minnesota with non-significant results, nothing is statistically significant. So what do we do? So here's Minnesota. They say, we conclude that the intervention is unable to generate enough additional exposure to exceed the remarkably favorable secular trends that are ongoing in the study communities. So what's happening in that 6 years of intervention is everybody's starting to know about these risk factors. So the American Cancer Society, all of the local community groups, people are out exercising, and they're doing these all over the United States. They have the Great American Smokeout. So this is contributing to a greater awareness of cardiovascular disease risk factors, but a greater change. And so everybody's changing, right? Everybody is changing. And what we're trying to do is get that net change so our treatment city change more than the control cities. And Stanford was able to do that probably because of the communications and the way we did that better than Pawtucket in Minnesota. But overall, there was not these favorable net declines. So what happened? Okay, small number of analytic units, right? Strong secular declines, countervailing negative forces. So the tobacco companies and everybody, they're always ahead of us in public health, right? So they're out, they're advertising for fast food, for tobacco, they're on TV, they're in all the magazines at that point. So they're countering all of what we're trying to do with our little, 26 hours of exposure is a lot, but they've got lots and lots of money, millions and billions of dollars going in it to counter it at the time. So here are the large secular decline. Oops. Here are the large secular declines. So here are the deaths. Here's a rate, right? Deaths per 100,000 population. And here's the difference. And look what's going on just in the United States from this time. So here's all causes. All causes are going down, but look what happens at that point. Treatment and control cities and everybody in the United States combined, CVD is changing and going down 54%. And look what's happening to stroke. So stroke is going down almost 62%. So you have this amazing improvement in cardiovascular health in the United States. And you've got these 3 studies that NIH is banking on, and they're trying to get change above and beyond these huge, huge secular declines. And here's kind of the final, broadening the concept of prevention in places. And so what you really have to do is, instead of just providing knowledge to people, right, you have to go and start really changing the environment in which people live, because those at greatest risk are going to be those with the fewest resources to change. And that is certainly how we've done things since then. However, the kinds of things, so there's a limited focus on the broader societal factors, right? Burden of change stays on the individual. You might get something in Spanish, you might get something about your cholesterol, but you still got to go out and have the resources, the time, and the motivation and knowledge to change the risk factors. Here are the contributions. So it set the stage. All of these 3 studies set the stage. They were the models, the methodology, how to do evaluation. They were great as far as advancing how do you social market, how do you communicate, how do you get communities from all sorts of government, nonprofits, churches, schools, how do you get people to sit together and talk about behavior change and come to strategies that everybody agrees on? And how do you then develop these risk reduction, health promotion methods and materials that are state of the art? So the big contribution is that this moves the field forward in a great manner to provide the health resources to large numbers of individuals with the recognition that the broader social environment is what we have to target from here on. And here's the next generation of CV interventions that you're going to combine. You still have to combine targeted individual approaches, but you better do a lot population wide, and you better address factors both in the physical and the social environment, and most importantly, policy changes. So this is the kind of thing in my next 20 years of research is I intervened and communicated and partnered with communities to really do policy changes, to open schoolyards where they hadn't been open, to repair sidewalks, to open gyms for teenagers to exercise, to allow food stamps to buy healthy kinds of things, to get hospitals to start changing their menus, to get churches to quit only serving donuts to serve healthy kinds of things, to get schools to change from unhealthy snacks at sports events and their snack bars to healthier snacks. And following Five City, here's Jack again, our center founder. And here's the county health department over Monterey and Salinas. And they win the C. Everett Koop Award, he's the US Surgeon General at the time. And so they won the award for being the health department out of the thousands of health departments in the United States as being honored with the best health promotion and disease prevention program that year. And here are some of the selected publications. And here's our goal. Manning Feinle, you probably read some of his work, but you have to put the change process in the broader social context, because you have a growing heterogeneity of communities, right? Complexity of community dynamics and structures that you can't tell what's going to go on economically. Is COVID-19 coming along? Is the steel mill going to close? And any of the countervailing societal forces, such as the tobacco companies who are now into vaping, right? And promoting that impact the change process and impact us being able to live healthy lifestyles. And this, I think we're done, aren't we? We're out of time. So this is just for your own benefit, that it tells you kind of the limitations, and here are all the challenges as far as communication and leadership and evaluation of these community-based cardiovascular interventions or intervention in any of the health effects. And here's how you strengthen them. So thanks for your attention.
Thank you, Marilyn. I'm just going to close with a few minutes of wrapping up for y'all. That was so wonderful to see that synopsis of that huge body of work. If I'm going to just, if you could unshare, Marilyn, or if someone could, there we go. I want to just show you guys the lemonade that I made coming in. As Marilyn was talking about, there was a great deal of sadness in the Five City Project about the fact that secular trends were overwhelming the ability to show an effect of the intervention. But we did manage to take some advantage of that as well, because of course the control communities had this exquisite examination of secular trends. And so we had a JAMA paper, this paper looking at this in adults and improvements in cholesterol-related knowledge, behavior, and plasma cholesterol levels in the control community. And then another paper on looking at this in youth. And this is really the main findings. I always encourage folks to summarize their main findings in an image. And you can see these are the two control communities. There we go. And you can see that over time that knowledge improved, that behavior, cholesterol-related behavior improved, and plasma cholesterol levels went down. And so that was a way to take what was a real thorn in the side of this investigation and be able to use it to say, yes, this concept works. It's just that it was writ large over the whole country and worked so well that it drowned out additional intervention effects. So thank you for sharing that. And I hope y'all can see the extraordinary principles that Marilyn and her team brought to doing this investigation. So this is our last class and our last moments together. And it makes me really quite sad and nostalgic being able to teach a class with you all and have an excuse to be able to bring in leaders in public health like Dr. Winkleby and share them with this extraordinary cohort of public health leaders themselves, students in this course. It's been such a pleasure. We just wrote a little report to WHO on teaching the course and talked about how much insight we've heard and how inspiring y'all's dedication to your work is. It's been a real pleasure working with you. I hope that you'll feel free over the next couple weeks and also ongoing to contact us with questions. We'll make sure that in our final communications that our emails are multiply plastered in there. There have been several projects that have come up where there's been some interest in our potentially helping on them, and we're glad to hear from you about doing so with NextGenU or with other aspects of leadership in public health. We will be giving you instructions in the next few days about the final exam and about due dates for the final assignment. With that, oh, it's so sad to say it, but for those of you who can turn on your videos, please turn on and give us all a wave goodbye, and look forward to hearing from you all and to seeing, reviewing your wonderful letters to the editor and seeing the advocacy that y'all have learned to do as health leaders. It's been a real pleasure. Thank you for joining us. And with that, I will say farewell.
Bye. Thanks for coming. It's been wonderful to be with all of you.
Thank you so
Thank
much
you
for your
all.
hard
It's
work.
been a pleasure.
Thank you.
Learned a lot.
We've learned so much. Thank you so much.
Thank you.
Bye.
Thank
Bye.
you.
Happy holidays.
You as well. Thank you.
Oh, she left. She just left.
Thank you.
Bye-bye.
Bye-bye.